Well, hi everybody, I'm Sandy and welcome back to my channel. Today I want to talk about anesthesia in the pediatric dental setting. And when I say pediatric dental setting, I mean pediatric oral surgeon. I also mean general dentist, as some kids are getting anesthesia and sedation in a general dental setting as well. So just how safe or dangerous is anesthesia for the pediatric dental patient? We'll have to give it some perspective and look at the safety of anesthesia across the board. So we know that anesthesia these days across the board is very safe. The mortality rate of anesthesia across the board we think is less than 1 in a million. Okay, very safe. That 1 in a million includes anesthetics across the board, like I said. So that includes people who are having anesthesia for trauma surgery. That includes people who are having palliative procedures at near end of life, very sick patients, all kinds of patients. So if we took a subset of the general population and limited our look at healthy people having general anesthesia across the board, I suspect it would be far less than 1 in a million as the mortality rate. Okay, so anesthesia these days we know is very safe. Now, what about the deaths per million of anesthesia in the pediatric dental procedures? Well, we don't know for sure. Unfortunately, there's not any one website with mandatory reporting or anything like that where we can quickly and easily grab that data. The best research I've been able to find estimates that it's probably over 3 in a million, okay, a little over 3 in 1 million. 3 in 1 million is what those researchers were able to find as the most recent, and I think this was as recent as 2017. But they estimate that the number is much higher for the reason I just stated, that there's no one database and no mandatory reporting. It's very hard to know exactly how many. And by the way, that doesn't even account for however many near misses that we have, or problems that come up that are ultimately solved or that result in coma and brain death. We don't know that. So is 3 in a million a number that we need to worry about? It sounds pretty small, right? Well, not really. First of all, if it is 3 in a million, and like I just said, I think it's more, that's still more than 3 times the risk of death from anesthesia across the board. Okay, so if it's your child that's going to have some anesthesia for a dental procedure, I think you'd think twice about that if you knew that the risk of death was 3 times that of the risk of if the child had anesthesia for anything else in any other setting. Okay, so that being said, I think it's something that's important to talk about, so we'll just move on, and I hope that you'll subscribe if you're finding this information is important, and well, let's get to it. I will talk about not only what makes the setting so risky, there are a few factors, but then I'm also going to talk about the new guidelines. I have been beating this drum about anesthesia in the pediatric dental setting for 20-something years. My family is sick of hearing about it from me. But finally, the American Academy of Pediatrics came out with some guidelines for sedating a pediatric patient in that setting, among others, but guidelines for sedation and anesthesia of a pediatric patient in such settings. And I'm going to talk about why I think those guidelines are great, but in my opinion, they don't go far enough. And then we can get to what kinds of questions you're going to want to ask if you're taking your child or another loved one to have oral surgery or anesthesia with general dentistry in the pediatric setting. Okay, so first of all, what's different about kids, pediatrics in these settings than the population across the board? Well, pediatrics are not just small adults. Children are not just small adults. Now, I could get all into the weeds and about the technical differences, but if you want me to get into that and elaborate at all, please just tell me in the comment box below. But I will just assume that you want to take my word for that and not get all bogged down in the technical information. Children are not small adults. They are physiologically and anatomically different than adults in such a way that it makes resuscitation more difficult and more time sensitive, I would say. You don't have you don't have a lot of time anyway when you have a problem arise under anesthesia and you have to rescue a patient's airway or something of that nature. But in children, you really don't have much time. A lot of things have to be done very well and very quickly. And that takes a lot of experience. That takes somebody who does it all the time, has done many, many of these cases, and it takes somebody who's, of course, very vigilant. So we're going to get to that in a minute. Who should that person be? But that is a difference. The anatomical and physical differences in children versus adults makes for the anesthesia to be a little more risky. What else is different? Well, the environment in a dental office. Dental surgery is different than other surgeries. Why? Because the surgeon is always in the mouth, in the airway. Okay, the mouth is the airway. So the anesthesia provider's job is to maintain the airway and make sure that the patient is getting adequate oxygenization, okay? Make sure that the brain is getting oxygen, okay? Well, the dentist or the oral surgeon is in the airway. So that's an added potential complication. Is there blood dripping back down into the back of the airway? They have instruments in the airway. They have cotton balls in the airway. Yes, there are cases of children who were asphyxiated from cotton that went down the airway. Okay, so we share the airway with the surgeon. That's a very unique circumstance. Does that happen in any other case? Yes, it does. Endoscopy is another example. We're sharing the airway with the surgeon, but it just makes for another layer of risk. Okay, and finally, the biggest difference, the most important difference that I have been talking about for 20 years, like I said, amongst my friends and family, is who is the operator, who's giving the anesthesia. Well, across the board in general settings, if you've ever had any kind of surgery that required anesthesia or even a diagnostic procedure, like you had a colonoscopy or you had your tonsils out or anything you ever had done, okay, if you had a procedure and you had an anesthetic, you probably had two different people doing both those jobs, okay? So one person did the surgery or the procedure and another person administered your anesthetic. And each person was solely dedicated to his or her job, okay? There was no overlap. There wasn't any such thing as one person managing both, okay? Well, in the field of pediatric dentistry, and I finally see a distant drumbeat coming that this is changing, and I am so grateful for it. Up until recently, and still, I think, it has largely been the standard that one person does both those jobs. The oral surgeon does the procedure and also directs the anesthesia and gives the anesthetic, okay? Gives medication in the IV and then goes and tends to his job and then adjusts it or asks his assistant to adjust it somehow, but he or she is still having to do both jobs, focusing on both jobs, and is not solely dedicated to one task. In my opinion, this is the most dangerous and ludicrous way to give an anesthetic. The only comparable realm where this is the standard of care is in veterinary medicine. Okay, in veterinary medicine, the veterinarian administers and directs the anesthetic and also does the surgery. It's a whole other discussion whether that's okay, but I don't think that children in having dental procedures should be the one exception to the standard of care across the board and should have the standard that we have in veterinary medicine. I don't think so, okay? So, in my opinion, anesthesia should be provided by an anesthesia provider, and that means a certified registered nurse anesthetist like myself or a board certified anesthesiologist, and I guess there is something called a dentist anesthesiologist, and it's a fairly new specialty. I'm not going to get into it because I don't know much about it, but it does sound like a step in the right direction. I was able to do a little research and see that involves a residency that is years long, years plural, where they're doing anesthetic cases. I think that's a whole lot better than what we've had up until now. So up until now, we've had the oral surgeon doing the surgery and giving the anesthetic. Okay, now I can tell you just as a mother, okay, not even as an anesthesia provider, when my own children had to have some work done, I remember talking about this with the oral surgeon and asking about the anesthetic and having the oral surgeon explain to me exactly what he would plan to do. And when I voiced my concerns about this, the answer was, oh, we all all oral surgeons take some training. They all get some training in anesthesia. Well, what is that training? It's about 6 months in operating rooms. And I can tell you as a nurse anesthetist, it's that they're the ones that we give them the case that's going to be kind of easy and they're not going to get in our hair. So we give the oral surgeon resident who's got to get so many cases done before he can go out on his own and never show up here again, give him room 1 and, that's going to be kind of easy and leave him alone. Even with the best of tutelage, 6 months is not nearly enough time to become proficient in airway management, airway resuscitation, and anesthesia in general on the whole. It's just not. Okay, that's why nurse anesthetists and board certified anesthesiologists all have years of anesthesia training. Okay, so I remember talking about this with the oral surgeon, and the second thing he said was not only that he had had that 6 months of training 30 years ago, but he said that he'd never had a problem. Okay, so if you have this discussion and that's what the oral surgeon has to say to you or the dentist has to say to you, well, I've never had a problem. My opinion is that that's one good reason to just run the other way. Okay, because anybody who has not had to resuscitate an airway in 30 years or manage an airway in any way or ventilate in 30 years isn't going to be able to do it. Okay, it's a skill. It's a skill that you use. It's a skill that you practice. That's not somebody I want to leave in charge of my child's anesthetic care. No, I don't think so. So these are things you need to be aware of when you go to an oral surgeon's office or a dentist's office where they're giving anesthesia. You need to talk to them and ask them these questions, and nobody should be offended at being asked. There's a way to ask, but I think it's very reasonable to ask. Okay, so these are the main differences. The patients are all pediatrics, we're in the airway, and the separation of operators, for whatever reason, doesn't seem to apply in dentistry. So where do we go from there? Well, like I said, the American Academy of Pediatrics, it turns out in a joint effort with the American Academy of Pediatric Dentistry, came out with some guidelines that I think are fantastic. Okay, now guidelines aren't laws, they're not even rules. But it makes it a little more difficult for people out there practicing to not follow them, because now they're published, and of course if anything were to happen in any kind of litigation or discovery, people will compare what you're doing against the guidelines of your own professional association. So in general, it's a good idea to follow the guidelines of your professional association. Are people doing that? I don't know. Some are, some aren't. Among these guidelines, they talk about the definitions of anesthesia. They define it, and they define it using the American Academy of Anesthesiologists, American Society of Anesthesiologists, definitions. And they divide anesthesia down into subcategories. So they have sedation. There's light sedation, moderate sedation, and deep sedation, and then they have general anesthesia. And that's a continuum. Light sedation, moderate sedation, deep sedation, general anesthesia. It's a continuum of depth, okay? And the guidelines put forth by the American Academy of Pediatrics is that any child having deep sedation or general anesthesia should have a qualified anesthesia provider. And by that they mean a certified registered nurse anesthetist, a board certified anesthesiologist, or anesthesiologist dentist, which again, I don't know much about. So I think that's great. I think it is a huge step in the right direction. Just a few years ago, we didn't have that. I think that will go a long way in protecting patients from some of the adverse outcomes. It's not a guarantee, but it will go a long way to get our outcomes in pediatric dentistry to look more like our anesthesia outcomes across the board, which would be a great step. Okay. Here's why I think they don't go quite far enough. I just mentioned that continuum. Anesthesia is a continuum, and anesthetic depth is always changing throughout a procedure. I think I said earlier that the anesthesia provider watches and monitors that patient. We look at all kinds of things. We look at the vital signs. We look at the respiratory rate. We look at the oxygenation in the blood that we can measure by a little probe that sits on the finger. It's a little lighted probe. There's all kinds of information we get. We can see how they expire carbon dioxide. And when you're experienced, you put all these things together plus what you're seeing, and you are estimating a level of anesthetic depth. And then you look at what the surgeon is doing, and you see whether the surgery is about to get a lot more stimulating, a lot less stimulating based on what the surgeon's asking for, where you are in the surgery and whatnot. And you're constantly titrating the depth of anesthetic. And so in these cases where you're inside the airway on a pediatric patient, you're walking a tightrope and you're constantly adjusting the anesthetic so that it's just right. Sometimes I liken it to an analogy of gymnasts when they jump up on the balance beam. If you've ever seen the Olympics or the gymnasts, they take a big running start, they get on the springboard, they jump up and they get on the balance beam, and they often do one of these. Or they do one of these, and then they right themselves. And then sometimes they go along the routine, and then suddenly they'll tilt a little bit, and then they right themselves. Well, that sort of happens in anesthesia. You have too deep, perfect, too light. Okay, too light and the patient's coughing and bucking and moving around, and the coughing can create an issue if you've got blood or instruments in the airway and whatnot. And too deep and your patient's not breathing enough. And that's kind of why we're here talking about this. So you're constantly titrating the anesthetic. And the truth is, patients move from one plane to another all the time, constantly. And our job is to either back it up or deepen it down so that we can get it back exactly where we need it. So these guidelines that we have by the American Academy of Pediatrics are recommended that we have a separate anesthesia provider when we are planning deep sedation or general anesthesia. But I would posit the argument that when we are planning any kind of level of anesthesia sedation, that we should have this separate anesthesia provider, because like I just said, you can plan for sedation to be light, and you can plan for the sedation to be moderate. But at any given time, you can end up with a deeper than intended level of sedation is what we call it. It happens a lot. To get a deeper than intended level of sedation, you have to be able to back it up, or you have to be able to intervene if the situation calls for it. And so, just because you go in and the plan is to have moderate sedation, or your oral surgeon tells you, oh, no, don't worry about that, because we're not going to plan for that. We're just going to plan for light sedation. We're just going to plan for light sedation. Well, that's great. But there's no other area of anesthesia where I practice where I start out with a plan that has to work. Okay, that's the whole thing about anesthesia, is you can't get yourself into a corner and have a plan that has to work. So I think it's great that the American Academy of Pediatrics has done this. I think it's a tremendous service to children and parents and society at large. But I will stand by what I've said before, which is that it does not go far enough. If it were me, if it were my child or the child of anybody I love, I would ask them to ask a lot of questions and make sure to have a dedicated anesthesia provider in that procedure. Okay, so anyway, I guess I'm going to wrap it up at that. I know I said I was going to talk about the issues, differences, pluses and minuses of hospitals versus surgery centers, and I do intend to get to that, but a friend, I was so happy, reminded me about this topic that I've been so passionate about for years, and I really wanted to make it my next talk. So I hope you've enjoyed this. I hope you'll subscribe. And please put comments in the comment box. Yes, I'm working on the eye contact. I'm still new and I'm trying to get comfortable with this. And please feel free to leave comments on suggestions for future video topics that you'd like to hear about. Thank you so much, and I'll see you next time. Bye-bye.